Yes, hello everybody. Welcome to the JACC Asia Pulse. Uh, my name is Jeehoon Kang, and I'm working as the specialty content editor of JACC Asia Pulse. And from now, we have a few series related to the cardio-oncology field, which is a very unique field, very important field. And we have 6 episodes that will be posted consecutively. So this is going to be the first session. So I would like to introduce Dr. Shen from UCLA, and he will host this meeting. Dr. Shen, please.
Thank you, Dr. Khan. As Dr. Khan mentioned, today we're going to kick off our cardio-oncology series, and I will introduce the 2 new faces today. We're happy to have Dr. Novi Yanti Sari, who's joining us as a host today. Novi is a cardio-oncology specialist based in Siloam Hospital's Lipo Village in Indonesia, where she established Indonesia's first ICOS certified cardio-oncology center of excellence. She also serves as the social media director for JACC Cardio-Oncology and helped create this collaboration between JACC Asia Pulse and JACC Cardio-Oncology. And we'll be seeing Novi in our upcoming episodes too. Welcome, Novi.
Hi, everybody.
And it is my great honor to introduce our expert speaker today, Dr. Eric Yan. Dr. Yan is a clinical professor of medicine at UCLA and the director and the founder of UCLA Cardio-Oncology Program, which was established in 2016. Dr. Yan also wears many other hats at UCLA, including being a cardiology liaison on the lung transplant committee, a member of the structural heart intervention team, and the associate program director of the UCLA Cardiology Fellowship. And also, he oversees the cardiology collaboration between UCLA Medicine and second affiliated hospital of Zhejiang University, located in Hangzhou, China. We find no better person than Dr. Yan to kick off our cardio-oncology series and discuss the rise of cardio-oncology as a specialty and why it matters to Asia. Welcome, Dr. Yan.
Thank you, Dr. Sheng. The honor and privilege is mine, and it was a really delight to have met all of you in person very recently at the QICC meeting in Hangzhou. It's always just an amazing setting, both technologically and just geographically and culturally, to see all of you be a part of this rising movement. So again, the privilege and honor is mine. So thank you for having me.
Thank you. With that, I'm going to post our first questions to Dr. Yan. What is cardio-oncology, and why does Asia need it now?
Yeah, so I get this question a lot, and even locally in Los Angeles, I think we get a lot of interesting perspectives of what it is. I think the funny thing is that many people automatically assume it deals specifically with primary cancers of the heart, and although those are very interesting and very fascinating cases, they are the vast minority of what we address. Really, in the end, cardio-oncology, the purpose of our field and the reason why our field exists is because our cancer colleagues now have been so successful in developing for the past few decades so many therapeutics now that are prolonging survival for patients across the world. We're seeing it in the United States. We are certainly seeing trends in Asia as well. And because cancer in some ways is becoming like cardiovascular disease, where it is becoming a chronic disease state. I think many of us, especially cardiologists, we have this stereotype that you have cancer, this is a palliative end stage, especially for advanced, cases. But now, just like heart failure, just like coronary artery disease, or advanced coronary artery disease and these advanced states, and people can live many years with, systemic or targeted treatments. And as a result, cardiovascular disease may be a top cause of morbidity and mortality. In fact, it already is for many disease states like prostate and breast cancer. But the issue is, and what it's important about to realize, is that many of us, unfortunately, still think of cancer patients as cancer is the only thing that is important. And it's important to realize that we have to maintain it's very important that many people may live longer than we think they do. And frankly, some of them may outlive, they have better survival rates than, frankly, heart failure or people coming in with disease states like myocardial infarctions or cardiogenic shock. And And I think it's very important that we appreciate that. And it's our job to educate our cardiovascular colleagues and internal medicine and primary care colleagues about how this population still needs ongoing attention to the risk factors, which also, on the flip side, may also contribute to ongoing cancer risks and everything. So we're learning more and more that heart and cancer risk is more intertwined than we think. And in the end, really, it's all about, addressing heart health in cardio-oncology. And, Asia certainly has a large cancer population. We all know this, that it is over half of the world's population, and there's over 10 million new cancer diagnoses every year. And as a result, we're going to see more and more high cardiovascular burden and cancer kind of come together more as chronic disease states, where many world citizens may be living with both issues that can be controlled medically.
Thank you, Dr. Yan. It's very true that with the rise in cancer survivorship and more novel therapy for cancer, protecting our patients from the potential cardiotoxicity from cancer therapy is so important, especially in Asia with its large population. With that, I'll hand over to Novi for our next question.
Yeah, that is really fascinating, Dr. Yan. May I ask, as a cardio-oncology expert from the US, how to get started? I mean, what are some major points that clinicians need to know if they are seeing cardio-oncology patients, like referral triggers, baseline tests, minimum viable service? Just like a quick introduction to everybody about how to get started.
Sure. Honestly, Dr. Sari, you are asking really one of the questions that has become one of my, I would say, favorite interests within cardio-oncology. It's not necessarily the science, it's how do you start the systems of care. Okay. And this is the challenge because we are I think we're the only, or one of the few only fields in cardiovascular medicine, other than maybe cardio-obstetrics and cardio-rheumatology, where we depend on an entirely different field of medicine, right, for the patients to care for and how to get buy-in and partnership. But I have some good news because you know what? This is not a rare disease state. This is not like we're looking for valvular disease or rare genetic cardiomyopathies. Cancer is already a huge patient population in everyone's backyard. Why? Well, at least in the United States, it's the second top cause of death. It makes up a huge portion of most healthcare enterprises, and I think I can assume that safely for most hospitals in the world that cancer burden is a major, major source of resource utilization, care, and revenue. And as a result, the patients are there. The question is, who do you take care of first? And this can be a very overwhelming challenge. And what I usually advise people who are interested and passionate about the field and want to start programs is to first start small from the ground, start from the ground and work your way up. And the more important thing is, in the end, it's about partnership and relationships. Because like I said, we are dependent on our oncology colleagues to provide the patients and to work with them. And what I would advise is when you are starting with a program, you want to meet with their leadership and identify the gaps in care immediately. And this is very important because it may not necessarily be aligned with what you personally care about. Like, for instance, when I first started, of course, this was before immunotherapy really took off. I was more interested in radiation-related heart disease and side effects. But my cancer colleagues, when I first talked about them, they cared more about breast cancer cardiotoxicity, side effects from taxanes. We have a huge stem cell transplant program. So we were dealing with a lot more heart failure, anthracycline cardiotoxicity, but ultimately they showed that these were the problems that they needed our help with the most. And you need to focus all your clinical resources and your availability to help with those, but at the same time to also make your team and your department and leadership aware that this is a field that frankly requires very fast, response accommodations for not just clinical care, but for imaging. As you all know, cardio-oncology requires a great deal of high quality imaging to look at cardiac function, signs of cardiotoxicity, and to also be able to have your clinics and your inpatient time available for those things. If you align with them on that, then you can start to expand to other fields of cancer. And the reason why I say this is because every healthcare system is different. Everyone has different cancer populations. Not everyone will prioritize the same issues. You need to look at what your strengths are in your cancer center and really focus on the cardiovascular care of those patients. Don't assume just because you like one field doesn't mean that it's the same as theirs. And it's very important that you know what they find is important, what they value. And that is the best way to start forward about how to help your cancer colleagues. And the more you provide the great care for their patients and they start seeing better outcomes, then you will start seeing other referrals for other disease states as you work through sort of their vast group and kingdom of cancer, cancer patients. I hope that answered your question.
Yeah, that's really fascinating. When I first started my clinic, as you, Dr. Yang said, we need to start small. And I only have like one oncology colleague who's really supportive. And that's how we got it started.
Yeah, and that's
Amazing.
exactly, I think, and it's okay because you educate one oncologist at a time, and this is where it is, and this is kind of the reality, I think, for the field is because until we have more systematic, wide, standards, although I know they're starting to become more and more guidelines out there, we know they may not always be applicable to every single healthcare system, right? Due to resources, due to interest, and the more, I think, the best way to gauge to get interest from, it's not just within cardiology. You have to also engage the oncologists. And I think the thing that we have to be careful about is that we don't just keep talking within our own tribe with our own cardio-oncologists. We also have to reach across the aisle more frequently and engage our oncologists because we have to also know what they care about and what's important to them. And that is the best way, I think, to have successful relationships and program building. And therefore, then, both sides will see the value in what you're doing and providing for a major, I think, a major population in most healthcare systems.
Great. Okay, hand over to you, Qicong.
Thank you. Our next question for you, Dr. Yan. What are some regional realities and challenges in Asia in terms of cardio-oncology?
Yeah, this is actually a very interesting question. And I will say off the bat, I'm certainly not an expert in all the geographic differences, I think, because, of all the different countries, all the different socioeconomic sort of areas, right? And I think this is why, going back to, what Dr. Sari and I were talking about is you really need, and also, like I said, I feel like even with the recent European Society of Cardiology guidelines, it's not to say that they are certainly well-meaning, but a lot of the biomarker and imaging testing may not, frankly, be available at a lot of settings throughout the world, not just Asia, right? And I think this is why it is critical to really pinpoint the most vulnerable sort of populations in your area, in your geography, to make sure that they have access to care. I think that, and this is something that I know probably Dr. Sari can comment on in her area where she works, Dr. Kang in South Korea. But I think we know that even those two places are very different in the kind of access and the settings that they have, but we know cancer is still a very, constant burden. How do you link that to the best cardiovascular standards? And you really, again, want to emphasize and maybe focus on the most cardiotoxic vulnerable populations. And by that, I usually mean things like, anthracyclines, HER2, and also, frankly, immunotherapy is growing and more accessible, right? And to have a basic sort of a line service that you can identify toxicities, not just cardiovascular toxicities, but maybe just other things that can affect cardiovascular risk down the line. Again, it's really about picking the most high yield places and high yield sort of populations. And even in the United States, I have learned that there are pockets of areas where we don't perform as well. I think it's, I was in Hawaii visiting some former fellows at Queen's Hospital, and it's very interesting to know that actually, for instance, the API population there, which tends to be more Pacific Islanders, their breast cancer survival rates are a lot lower than the national average, And speaking in Los Angeles, we have also a large population. I'm sure Dr. Kang and Dr. Sari are aware of, hepatocellular carcinoma being such a big issue in Asia, right? Of VEGF inhibitors and the immune checkpoint inhibitors are now being more and more used for advanced disease. but also Los Angeles County also has higher death rates above the national average. So this gives you just an idea, just even within other supposedly technologically advanced societies or where we have good health care, there's still, gaps in care that are somehow contributing to worse cardiovascular and cancer outcomes. And these are the pockets of people that we really need to target. And each, engaged cardio-oncologist should also be aware of which patients, frankly, have these kinds of outcomes. And this is something they can work with their oncologist to also help provide cardiovascular care with the resources they have. And this is why I'm saying really good, close communication about identifying these vulnerable populations, not just cardiotoxicity, but also patients who are more likely to get, cardiovascular issues should be focused on the first and foremost. And definitely making sure, for instance, that they have imaging protocols for anthracyclines, which I would argue I think is probably the most important. HER2 monotherapy probably is less as necessary, and obviously I'll defer to Dr. Sari about how often that's being used, but anything combined with anthracycline certainly is underscreened overall internationally, and that's something we should be doing more of. And obviously other things like if you have more unusual use of immune checkpoint therapies, these are very also important to kind of educate patients about rare side effects like myocarditis, because as you know, more and more patients will be using them. We were just in China. They have a much higher, portfolio of immunotherapies, which I also find very fascinating. And I can only imagine that the overall incidence or the overall numbers of patients that are going to have potential complications are likely going to rise. So figuring out also education efforts of oncologists and patients to advocate for themselves is also very, very important.
Yeah, thank you, Dr. Yan. So true that knowing the patient population is so important. And taking ICI myocarditis for example, you were educating us at QICC last month that ICI now is used in almost half of the cancer types. And ICI myocarditis has a incidence rate up to 1%. And with large populations in Asia, there are probably a lot of cases that went unrecognized with ICI myocarditis with a mortality rate of 30 to 50%. There are currently some preliminary data, with the optimal treatment, namely beta-sapt, ruxolitinib, and steroids, we can really drastically lower the mortality rate. So it's very important to have that piece of a history of ICI therapy in mind and knowing the patient population, have the initial suspicion so patient can be started on the right treatment and such.
Yeah, no, that's what I'm saying. And I think now our understanding of these toxicities, not just cardiovascular with immunotherapy, it's going to be more and more frequent. And it's not something that all just cardio-oncologists are frankly going to always be aware of, especially if there's only a couple of these individuals in each hospital, right? I think toxicities are going to affect the mainstream healthcare, right? And if you have someone like Dr. Kang, who is doing an angiogram on someone with suspected, suspected acute coronary syndrome with someone who just had immunotherapy, for instance, 1 to 2 months, he will know once the cath is normal that something else is going on, right? And this is something that to activate or to be aware of. And my argument is that this is not just something that a niche field, a small band of doctors in the world need to know about. This is something the whole cardiovascular field is going to know about, given how much, more frequency we're going to see these issues. And it's not necessarily that we expect every cardiovascular doctor to know how to manage myocarditis or these very unusual toxicities, but at least know to recognize something is going on, possibly related to cancer therapy, and to get the right people in to help treat and identify it. And this is also, I think, a challenge we have as a field, because we're trying to always catch up with the big tidal wave of cancer therapeutics that are literally coming out by the week. And it's exciting, but it's also very daunting because we're still trying to understand and address all these issues.
Wow. It's really, really fantastic. And as Dr. Yang said, I mean, challenges is always happens. And of course, it's going to be different. I mean, like developed country versus, developing countries. Like, for example, I was trained in Singapore and the system is, of course, very different from back home. And in Indonesia, it's kind of like interesting because imaging is, I mean, like echocardiography with GLS, we did it more often than we did for biomarkers, because biomarkers like NT-proBNP is not necessarily covered by the National Health Insurance. So we did more echocardiogram rather than biomarkers. So we're gonna talk a little bit, about the follow-up, and then as you said, we need to really focus on most for the most high risk cancer patients, as you
Right.
said. And maybe Dr. Yang, for the last questions, maybe any parting words for cardiologists or oncologists in Asia? What's the, call to actions?
I think, I think the big strength Asia has is, again, just kind of pointing, it's its sheer size, and I think, and I know there's a lot of challenges to this in general, but this is where I think institutional registries of like getting cardiologists and cancer doctors to not just, you know, just track outcomes in silos or different pockets, right? Because obviously we have a lot of cardiovascular registries, we have a lot of cancer registries, but we really need to start having the conversation on a global scale of how to start like looking at both these things. Because frankly, like I said, most of these disease states are going to come together in a chronic, people are going to be living side by side. I envision a future one day where, someone's going to live with coronary artery disease, and also maybe stage 4 melanoma because it's stable because they're getting their pembrolizumab every month and they're on a statin and aspirin and blood pressure meds, and how that all ties in together is something we still need to understand. But I'm just saying, like, this is kind of where I think cancer therapies have evolved, where people can have relatively normal lives at the price of a pill or an infusion. And as cardiologists, we can't just dismiss them as, oh, you're not, still have very good quality of lives. And there's still obviously a lot of other serious cancers that unfortunately are not great, but also this is an opportunity to still be a part of managing care to also get them through treatments. We obviously haven't gone through all the different avenues of what cardio-oncology can do for the cancer patient. But the way that we can truly understand that, though, is to get this kind of real world data about outcomes, the kinds of cancers and how they are addressed and dealt with, and the cardiovascular issues that they address. And this obviously may not be possible through all different Asian countries, but I think definitely within each country to have some of these registries. I know, for instance, the in China, at least, there is an equivalent of I think like there is a CCC, a registry looking at acute coronary syndrome outcome, like outcomes and things like that as a QI sort of initiative. And I think in a lot of centers in Asia, there are already very prominent cardio-oncology places where that can be done. But obviously that just requires a lot of partnership across the aisle for all centers and also within cancer and cardiovascular, groups to make this a possibility. I mean, of course, it's going to take a while. We are struggling still to do this in the United States, but I think one day, in order for us to really understand what we are doing is making a difference, will require that degree of, that effort. And I think it will be very, very interesting, and it will be hopefully really beneficial for all our growing cancer population.
Yes, thank you, Dr. Yang, for sharing your perspectives. Obviously, the cardio-oncology field is a very rising field, and actually, when I started my fellowship, I thought that I graduated from anti-cancer agents except anthracyclines.
Yeah.
But suddenly, immune checkpoint inhibitors came into the field, and then now it's like, as you said, we have to know that something unusual is happening, but now this unusual is not unusual. It's a usual thing that can happen. So we have to be aware of it. And I think that I suppose that all of the listeners of this video will get inspired by your talk and your perspectives.
Okay, I say one last thing real quick?
Sure.
Just for all the trainees and people interested, or no matter where you are in your career, the best part about this field is it is a populist field, meaning that you can make something out of anything, even at your local institution. You want to make a difference, you can look at just trends and outcomes, even in your own hospital. It can be meaningful science. And it just requires obviously a lot of interest and a lot of heart, sorry for the pun, but it is true. But like you just want to, you can make a difference locally, and that can actually translate to bigger sort of questions that the whole cardio-oncology community can investigate on a bigger level. And that's what I love about this, because you might be like, well, I'm a medical student, I'm a resident, what can I do? I'm like, well, actually, you can do a lot, because any question you ask in the field, chances are we don't have a good answer for it, and this is why anywhere, any part of the world, you just have to have a open mind, be willing to say, I don't know what's going on, because I say that every day, and also like willing to kind of get the data and put it together. So sorry, that was all I wanted to close out by saying.
Yeah. Thank you for your final speeches. So it was a wonderful interview with Dr. Yang, and I would like to thank Qicong and Novi for hosting this. And I hope everybody has a nice day. Thank you, everybody. Bye.
Thank you.